Hey everybody, and welcome back to another edition of the Physiotutors podcast. We have with us Pat Camp, a physiotherapist specialising in respiratory rehabilitation, educator and researcher. Next to that, Pat also has a fantastic podcast called LungFit, talking about respiratory rehab in easy to digest chunks. So we're going to enjoy talking to her today about the rest physio current knowns and unknowns, and we're going to touch on as well Covid-19. So Pat, look, I've tried to give a little bit about you. Why don't you take a couple minutes, tell us more about who you are, what you do, and then we can jump on into the world of pulmonary and respiratory physiotherapy.
Sure, and thank you very much. Thanks so much for the invitation to come onto your podcast. This is a really wonderful opportunity to talk to more physios out there about some of the work that's happening in pulmonary related physiotherapy. So, like I say, my name is Pat Camp, and I am from Vancouver, Canada, and I have an opportunity to both teach and do research as part of my appointment as an associate professor in the Department of Physical Therapy at the University of British Columbia. I'm also a principal investigator at the Center for Heart-Lung Innovation, which is a research center, and that's located at St. Paul's Hospital in downtown Vancouver. So if you've ever been to Vancouver, we've got this great old brick hospital, which has been around for over 100 years, and I have a research lab there. And fortunately, I've got my lab right over top of the pulmonary rehab program. So pulmonary rehab, respiratory rehab, it's the same thing. So you'll hear it referred to in that
Interchangeable,
way.
yeah.
Interchangeably, yeah. So I've been working in pulmonary rehab since I graduated from physical therapy back in the 90s, and I've been on faculty, I guess, at the University of British Columbia since 2010. I got my doctorate in 2008 and then have been working in research and teaching and involved in some clinical practice and lots of service obligations. So really happy to come and talk to you today about pulmonary rehab.
Oh, fantastic. Whenever I touch on a new topic on the podcast, I always like to touch on the basic anatomy, physiology of whatever problem it is that we're going to be discussing. But I think if we do that, as I gave to you in the questions, we're going to be sitting here for hours just talking about that physiology side of it, the anatomy side of the airways and whatnot, before we even touch on any kind of conditions, any kind of issues that someone might face. So we're going to sort of skip over that and come to it as and when necessary when we're talking about particular conditions, but we'll try to keep it as clinically relevant for the listeners as we can. So look, what would you say have been the most common pathologies or complaints that you've seen as over your time as a researcher, as a practicing physiotherapist?
So when I first started in pulmonary rehab, by far the condition that was most prevalent in our rehab program was COPD, chronic obstructive pulmonary disease. And there really was very little available to patients with COPD back then. It wasn't even very well known as a condition. I'm sure many of your listeners will remember when that was a kind of a well-known term amongst them clinically, but if they said it to their friends or family, no one would really know what COPD was. So by far, most of the patients that we had COPD. What we have noticed, I guess, happily, fortunately, is now more patients with pulmonary fibrosis are coming into our program. And I think that's a result of more specialty clinics, more respirologists who are specializing in pulmonary fibrosis, all the different interstitial lung diseases. They're seeing patients in specialty clinics and they're referring them to pulmonary rehab. And the evidence base to support care for people with pulmonary fibrosis is also growing. So those are probably in our program and in many programs, at least in Canada, the two most predominant respiratory conditions. We certainly do see people that have asthma or people that have cystic fibrosis. Often people with cystic fibrosis might go into a separate pulmonary rehab program. Also, patients that are potentially on a transplant list, either pre or post, I guess. Transplant will come through pulmonary rehab. And then to a smaller degree, you may see patients in some programs that have undergone thoracic surgery, perhaps for lung cancer, patients who are post ICU and have deconditioning and are coming through a program. And then some of the more rare conditions potentially may also be referred. So it's often a referral based on challenges with the patient's function. But by far, most of those patients have COPD and now I would say an interstitial lung disease.
Okay. So if we stick to the COPD, first off, what are the sort of complaints that people are going to be having? And then where can we as physiotherapists have the biggest effect? Because it's not exactly something we're going to be reversing time on, is it?
Yeah, that's true. I mean, interestingly, it's one of the body systems, the pulmonary system, that really doesn't improve with exercise or with rehab compared to, say, cardiac rehab or musculoskeletal based programs. But patients that have COPD come to us because they have shortness of breath, and it's usually shortness of breath with activity. They have fatigue and tiredness. They have muscle weakness. And then they have all of these things are impacting their quality of life. They often don't have the skills that they want with respect to understanding how their medications work and avoiding exacerbations. And things like end of life planning and understanding what a hospital stay might mean for them. So from an education and behavioral support perspective, there's lots to offer there. So it is the condition for which pulmonary rehab has, I would say, the strongest evidence base to improve exercise outcomes and quality of life outcomes.
Okay, so working on what you just mentioned there at the end, exercise outcomes, how do you approach those initial stages of rehabilitation? What are you doing in clinic? If someone comes into clinic for myself, let's say with COPD, what should be my first port of call if I'm looking to assess and looking to start treating this person?
So like all your patients, doing and testing their exercise capacity is quite important. Many of the higher level, higher resource teaching hospitals might do a cardiopulmonary exercise test to be able to get a VO2 peak and maximum workload, and to actually be able to base their exercise prescriptions from that, which has a very strong evidence base and has great outcomes. But a lot of programs don't have those sort of resources. So they might do something like a field walking test, such as a shuttle walk test or a 6-minute walk test. And both of those are really excellent indicators of exercise function, exercise performance, I would say. And you can also use them to create an exercise prescription for your patient. And so there's some great resources that allow you to make those calculations that are available to clinicians. And then from that, it's often a basic 60 to 80% of their maximum capacity. And that range allows you to be able to adapt your exercise program based on their overall function, their frailty, their comfort with the equipment. The principles of exercise are 2 to 3 times per week around with the aerobic exercise, usually about 30 minutes or so per time, working up to probably 30 to 40 minutes. And then a regular progression, hopefully on a weekly basis, as tolerated. Often it's around 5% of their workload, but also taking into account their ability to handle their breathlessness. So there's really clear and structured guidelines to guide clinicians who are working with these patients around the exercise prescription. And similar for the muscle strengthening part too. Again, potentially doing something like a modified 1RM and being able to create your exercise prescription from that.
You mentioned that both the cardio and strength based, and if you're doing 2 to 3 times a week of cardio training, how often are they going to be strength training, and what sort of ratios should you be looking at to also keep it realistic for the patient to ensure compliance? Because that's the other side of the coin, right? Patients that aren't always going to want to exercise potentially 5 times a week, or 2 to 3 times a week sometimes can also be a hassle. So what sort of ratios are you going for with the people that you're working with?
Most programs try to do both types of exercise within the same session. So they'll have their patients come for a 1-hour session, And, with a bit of a warm up and cool down like normal, you would probably have about a 30-minute or so aerobic component, and then a 15 to 20-minute muscle strengthening component. And with the with any of those, always a strong reliance on rating of perceived exertion and Borg, starting off probably maybe under training to a little bit to begin with, just to have the patients get comfortable with the program, and then continuing on. And those programs run for 6 to 8 weeks. So you do have a good chance to build up some changes. Patients will start to notice some improvements, and also getting that behavior change part of it in place, and then transitioning to a program in the community where they can continue on.
Okay. I think that behavior change is always such a massive factor that gets left behind in the conversation. As physios, we're not psychologists, but at the same time, it is something that is part of what we do. It's within the remit of that behavior change. If you're going to use your Socratic questioning or something to help someone along their pathway, if you've only got an hour session and maybe you see these guys 2 to 3 times a week, what's your approach then when doing that? Because not only is that going to help them in the 6 to 8 weeks that they're with yourself, but also it's to ensure that there's no relapses and to ensure compliance for themselves when they're done with you, essentially. Because ideally, once they're done with the 6 to 8 week, there's no relapse, and they'll just keep on plodding along on their own merry way, right? How do you go about factoring that into your sessions as well?
Yeah, that's a huge issue, isn't it? Because a lot of enthusiasm can happen during a program. These are group programs as well, so people can really get on board with it and be pushed on and encouraged by the group. And then, they go home, and when the program's over, they can feel really adrift. And there's been quite a lot of research that's looked at, does pulmonary rehab, or many kinds of rehab, but focusing on pulmonary, actually have a change in physical activity? Do people increase their physical activity, which is a huge predictor of mortality and morbidity, or do they sort of compensate? Do they do their exercise in the program and then they sort of take more of a rest the next day, in a sense? And for the most part, the research interventions that have been studied haven't had a ton of success trying to get that carryover. I think that some of the things that as physios we've been introduced to, like motivational interviewing, has been, I think, quite helpful, so that people aren't just coming in and kind of being slotted into a spot and really not having that conversation about why are you here and what do you want to get out of it. I think that more peer support and having cohorts potentially, or at least small groups, being able to transition into some kind of a community-based maintenance program. Anecdotally, I've seen that work quite well in cardiac rehab, where they almost a group en masse sort of leave the hospital-based program, and then they head over to the sponsored program at the YMCA down the road, and they just kind of continue on, and they feel very empowered within that group to be able to support one another. I feel like in pulmonary rehab, we haven't had as much success. Our patients are often older and more frail, and they just maybe we haven't done as good a job maybe in making those transitions, that important transition from program into some kind of community-based activity. So I think it is a gap. The research certainly hasn't solved it yet. I'm hoping that maybe we can learn how to be a bit more creative in terms of taking something that is often quite sort of clinical and hospital-based and using a lot of equipment, and transitioning it, doing a better job transitioning it into more of a home-based or community-based program. And to add to that, I would say that some of the research that's coming out that is looking at low resource programs that use very minimal equipment, are potentially showing great potential, I guess, to be able to have patients use minimal equipment to be able to continue on at home. But again, those sorts of studies are just in their infancy.
Even though they're in their infancy, it's quite interesting. So what is it that they'd have people doing that's so different that would encourage that kind of turnover?
I think it's getting comfortable with just using simple equipment. I think we've had patients come in, especially to some of the big programs that have been really strong research programs. And so the equipment is top notch. We've got electronically brake bikes, and we've got great treadmills, and we've got beautiful walking tracks, and we've got lots of monitoring equipment. And while great to be able to understand the impact of our interventions from a research perspective, it's pretty hard to replicate that kind of environment out in the community. Also, maybe the level of supervision that we have, where we have somebody there to monitor you, and we can potentially develop some dependency if that is too hands-on in a sense, and if we stay really hands-on throughout the whole course of the program. I think that programs and research that's starting to look at simple walking, good exercise, but also using simple equipment like TheraBands or just equipment people might have in the home, and just show them that it's quite feasible to have a really well-rounded exercise program without having a ton of supervision and a ton of really high-level equipment, might end up doing more benefit, providing more benefit in the long run, and also enabling more lower resource rehab programs to open up as well in communities. So I'm hopeful that that trend continues.
Yeah, absolutely. And what you're saying there about also trying to prevent that over reliance, when you guys get towards the end of your 6 to 8 week block, how is it that you taper that off? Or is it just that's it, 8 weeks bang? Or is it a case of in the last couple of weeks you start to ramp things down a bit? What are you guys doing there to help aid that? Because like you mentioned before, people feel like they can be sent off adrift once it ends.
Yeah, and I'd say that it's really up to individual programs how they handle that. I've certainly seen programs that are monitoring as intensively on the last day as they were on the first day. And maybe it just becomes a bit of a habit. Everybody sort of expects it. I don't think it's a bad thing for patients to feel like they can monitor themselves. So we used to say things like, like the oximeter sort of felt like the domain of the clinician. And we would say, oh, you don't need an oximeter for your home. You shouldn't rely on the numbers. But I encourage people to understand how their body is responding to exercise. And if that means getting an oximeter and looking at your heart rate and seeing in what ways, your oxygen and your heart rate change when you're exercising, I think that's a great thing. I have seen programs that, maybe just monitor a little bit in that first week, and then they don't, and they much more leave it onto their patient to be recording the exercise, to sort of take more charge. And then if they're having not a great day, or if they feel like something's off, then relying on the monitoring equipment to be able to do that. And so potentially those patients are more able to transition. But only a few programs have what I would call a more formal transition to a community program. So where they may have a more established relationship, where they can maybe have their patient go and visit that program partway through the formal program and just start to make those connections. I think that is a problem in the Canadian system. We don't have healthcare funding in the community in many settings in the same way. So it really becomes leaving your publicly funded healthcare and then trying to find something that is a community-based, now privately funded. So I think some of those transitions and those barriers really make it hard for patients to be able to go from A to B.
Absolutely. Like you say, it's not always possible. It's not always there. It is sometimes quite the barrier. What sort of tips and tricks do you tend to give to your patients to help keep them on the up and up? So perhaps it's something like breathing techniques or something. Is there anything that you give to your patients to give them a little bit more self-reliance rather than relying on coming back to clinic?
Well, there's a fair bit of emphasis in the program around things like avoiding an exacerbation, which is then probably one of the more major events in someone who has COPD in terms of affecting their overall natural history of their disease. So having an exacerbation increases, your risk of hospitalization, earlier mortality, and massive changes in function. So we do spend a fair bit of time encouraging people to avoid it, and we talk about ways of doing that. And then we also talk about things that you can do if you've had an exacerbation in terms of maintaining your function. And so graded or gradual walking programs, sit to stands at home, really thinking about functional mobility. When we have patients in the program, I think it is important to start early and talking about those transitions. And I have to say, that conversation is a bit mixed. I do struggle with that. Some people, they're there because the doctor maybe told them to, and they're not necessarily really seeing themselves as someone that exercises, or they just have a belief that they'll just continue afterwards, and then but they don't really have a plan. And then so I guess talking early about planning for what are you going to do. More and more people are liking wearing something like a Fitbit, and so or some other kind of wearable. So using different kinds of feedback mechanisms for that kind of behavior change, if that's what they enjoy and that's what they like to do. But yeah, it is a struggle. We certainly create home programs and things like that for people to continue. That is very much based on maintaining function. But trying to have someone continue on with some kind of a group program, or at least having a buddy maybe from the program that they can continue with, I think that has been more successful for some of those individual patients in terms of them continuing on.
Okay, grand. I want to come back to the exercise part of it in a moment, circle back to that, and ask you about how you guys work on your loading and your progressions and any metrics that you might use. But what you mentioned there, they're almost a buddy program kind of thing. How has that been for you guys now over the last year and a bit of COVID? As things have been shut down for quite some time. It's probably quite difficult to get X amount of people in the clinic all at one go. How's that been?
So far, no clinic programs in person have happened, period. And so the few programs that have been able to start up again have done basically a virtual rehab, which, after many years of working in research in this area and thinking about policy and how are we going to make a change in actual healthcare delivery, taking something that's research and, we've been kind of wondering about that for years. And then, it happens like 6 minutes with COVID.
You got 5 days go.
You got 5 days go, barriers dropped, I've been in committees where we've agonized for months over whether we should have this platform or this platform in terms of privacy. And then just so quickly, I think if anything, it has shown us that many of these barriers weren't really true barriers. But joking aside, I think that a lot of the programs that I know of really have just started. I mean, they're actually just maybe on their first, second, or third trial of a rehab program. So the patients that are able to access it are happy and are grateful. And if anything, they're they don't know what they're missing in a sense because they haven't been part of the group program. But a lot of them are quite happy not to have to travel to get to a rehab program. And so just anecdotally, our attendance, I guess, has been quite high. I'm not personally running that program. That program is happening at St. Paul's, the one I'm referring to, and just talking to the physios there, they're really quite pleased at how many people are attending. And I think it is so much easier for patients not to expend so much of their energy just to get ready to drive in and parking and walking and all of that, and then doing it all in reverse. So we're saving an enormous amount of their time and energy just by running it virtually. But of course, that's those smaller interactions, those meaningful interactions that we're missing, the chatting before and after or during the program, that isn't as easy, of course, on Zoom. So it's very much a focus on the physio, eyes on physio, and probably less opportunity for that casual connections to happen between people, those very meaningful connections though. So I think that might be a bit of a casualty. And I'm not aware of, I know that we have we have patient support groups that are meeting through Zoom, and those things are happening, but it's not quite the same as the sorts of connections that you make while you're exercising together or while you're getting a glass of water together in a program, that relationship that you build over all of those weeks. So that's a bit of a problem for sure.
Yeah, absolutely. I know on the few programs that I've been involved with, sometimes you could see it in their attitude. They just kind of phoned it in on doing the exercises, and they were only there for the coffee and tea afterwards to have a chat with their exercise buddies, as it were.
Mm-hmm.
And for a lot of them, like you mentioned, a lot of people within this population, not all, but a lot of people are quite old. They're quite frail. So this could be their 1 or 2 days of interaction a week. That's someone who's not either from the family or from a care home, if that's where they are, kind of thing. So you
Mm-hmm.
definitely see that. I suppose that also works its way back into the whole minimalistic approach of the exercise programs as well, trying to get rid of all the big fancy, or not get rid of, but utilize less of the big fancy equipment and make it more, hey, I did it at home for 6 to 8 weeks over Zoom. I can keep doing that at home. So that's also probably quite a nice bonus, and hopefully that helps people to keep going and gives them the impetus to keep going on their own. But with that said, then how is it that you guys then progress your loads, not just for the Zoom at home, but in clinic as well? What criterion are you using to say, hey, Mrs. Jones can ramp up on the exercise bike, or we can pop a couple kilos on, or give her a dumbbell while she squats, kind of thing? What are your markers that you're using there?
So, there's what the guidelines say. So I'll talk about that first. So like I mentioned, it's often based on, so for the aerobic, the 60 to 80% of the maximal workload, and that can be calculated from a cardiopulmonary exercise test or from a shuttle walk test. They're both considered maximal tests, and estimated from a 6-minute walk test. So from that, you can get usually a good starting speed for the walking, and whether that's done using a whole walking program or on the treadmill. Usually we start patients on sort of 10 to 15 minutes at that workload, and then guided by the heart rate and the SpO2 measures. So we try not to reduce exercise intensity based on oxygen saturation, but we certainly might increase the oxygen in order for them to be able to meet that exercise expectation. That changes from setting to setting. Not all jurisdictions allow the change in supplemental oxygen. So there's a bit of a practice role, I guess, there that may have limitations. Not all patients come with oxygen, and so putting someone on oxygen that isn't already prescribed, that also has some jurisdiction issues as well. And then some patients, you just can't provide an oxygen delivery method that enables them to get enough oxygen. And it's not exactly a hard and fast rule, but usually 88, 90% in there is where you start to, anything lower than that is where you start to look at making some changes. But having said that, if you can maintain oxygen saturations at an acceptable level, then that would be what the aerobic workload would look like. The guidelines say a similar sort of approach for the strengthening, the 60 to 80% of a modified 1RM, but I have to now say that very few programs are doing any sort of formal muscle strength testing in their program using any means. And so they'll more often go with a bit of a kind of an ad hoc, you're getting comfortable at 10 or then it's probably too easy, or, you should be feeling it at 6. So they're sort of doing a bit of a trial and error approach. The progression part, though, I think is probably the major part. I'd much rather see a program start off maybe a little too easy, maybe under training a little bit, especially if someone isn't familiar with exercises in their lives. But then having a real plan for progression. And I have done audits of programs in the past and have seen practically no progression from beginning to end. Everybody gets a little too comfortable. And I think that is partly where patients may be fearful and concerned about their shortness of breath or their oxygen. And so it really does require a certain, I guess, gift and expertise around the encouragement to be able to train harder. And I think it reflects badly on any program that doesn't really have a plan for progression, because patients will go back to their referring doctors and the doctor will say, well, how was it? And the patients will say, well, I didn't really notice a change. And no kidding, if programs aren't really being really thoughtful about that. So there isn't really a specific guideline, but most of the recommendations will say something like about 5% a week, with that expectation of doing that and then backing off if there's a reason, say that the patient has had a flare up or there's been some other issue. So with those sorts of guidelines, patients can see a really clinically important improvement in 6-minute walk test, oftentimes in maximal workload, in their measures of shortness of breath and muscle strength. So there have been some good physiological changes based on those kinds of exercise parameters.
And then what do you do if during the session, you mentioned already about increase in oxygen for people, but let's say someone does have an episode of shortness of breath, or they are desaturating. What are you doing for your patients there and then on the spot? Are you doing any pursed-lip breathing techniques or anything like that? Or
And sometimes those things are quite separate. So a lot of patients can desaturate and have no dyspnea at all, no more dyspnea. And then other patients can be quite dyspneic and really their oxygen levels are fine. So there can be a relationship, but there isn't always a relationship. So for the oxygen, the simple oxygen is dropping below the accepted parameters, then we will try to increase the oxygen amount. But there is only so much that you can provide through some of the systems, just, nasal prongs. Face masks aren't super comfortable, and a lot of the patients don't really have the high flow systems. So in that case, we might go to more of an intermittent or interval, but intermittent is probably the better word here, where, they'll have shorter cycles of higher intensity and then a bit of a recovery period where the oxygen levels can return. And so having that up and down, up and down, up and down for their oxygen is fine if they're given enough time to recover. They don't have to be completely, back up to 95% or something like that, but if they can get above that 88, 90%, and that's the kind of exercise program we'll often see with people that have interstitial lung disease, where their oxygen levels can just plummet. And then with a brief pause, they can come back up again. So that's what we'll see. For the dyspnea, that is often a separate mechanism that's causing that. And sometimes it can be made worse with the feeling of being anxious as well, especially if they're anxious about exercise. So if they have COPD, we'll often suggest pursed-lip breathing, which is really, pursed-lip breathing is a way to try to both control their breathing, control their the uncomfortable sensations of dyspnea, and also work to reduce the hyperinflation that's occurring in their lungs through trying to have a longer exhalation and having less trapped air in their lungs that can occur when they're exercising. It hasn't really been shown to be as effective with people with pulmonary fibrosis, but a lot of patients will try it anyway, just to have that sense of rhythmic control over their breathing instead of that feeling of having very sort of panicky shortness of breath. And so those breath control during exercise are some of the first things that get taught in a rehab program, often within a day or two. And so patients can practice it in the program, and then they start to practice it when they're out and about. And that can make an enormous difference.
So what sort of breath control techniques do you use aside from the pursed-lip breathing?
That's the main one as a way to try to prevent their dyspnea from getting out of hand. If they are finding that they're short of breath and they're uncomfortable, there's other kinds of breath control that is often more related to positioning. And so, as an example, you may suggest that a patient might need to use a walker, not because of a lower extremity issue, but because taking that load off, in a sense, of their thoracic cage and being able to brace their arms on a walker provides some support and some release or relief for accessory muscles. And so they can have a little bit more relaxation and be able to reduce their shortness of breath. And those kind of recovery positions can be used quite well if patients are, say, out walking and they're finding that they're getting shortness of breath during walking that's uncomfortable. They have to stop. Being able to position themselves on, say, a chair or a bench, and then leaning forward with their elbows on their knees, again, to kind of lock and brace their frame, or leaning against, a wall or against a ledge or something like that. Again, with that sort of slightly bent over position, not too far over, but just a little bit, and then being able to support their arms in some way. So we'll teach those as recovery positions, and then we'll teach the pursed lip breathing as control positions.
Okay, nice. And are there any other generalized breathing techniques that you guys might use to help people with their breathing at all?
Some may try to do just some relaxed breathing, almost as a meditation. Trying to force patients into something like diaphragmatic breathing can actually be somewhat unhelpful. Patients learn, especially with COPD, they have a flattened diaphragm, they have hyperinflation, they have already a change in their pulmonary mechanics based on those changes that are happening in their lungs. And so trying to force patients into breathing with your diaphragm when your diaphragm is in a structurally different place than normal can actually increase feelings of dyspnea for some patients, and it really can alter a pattern of breathing that they have adapted in order to be able to be the most comfortable. So if patients find it helpful, if they actually like that diaphragmatic breathing and the sensations and the calmness that many people enjoy when they have that, when they do that, then there's no problem. But if they do find that it actually increases their sense of dyspnea, that's probably an indication that they're trying to do something that isn't really helpful based on their existing pulmonary mechanics. So it's not something that's typically taught in a lot of the programs that I'm associated with.
What is it that's so different about their pulmonary structure that the diaphragmatic breathing is no longer helpful?
Well, with COPD, the destruction of the alveolar sacs and the changes in the airways result in a lot of trapped air that can occur in the lungs. And so residual volumes are higher. And so that actually has the impact of flattening the diaphragm continuously. So instead of your nice domed diaphragm that you'd expect to see if you looked at a chest x-ray, it's actually quite a bit flatter. And so that changes the pressures in the lung, the pulmonary mechanics of how we breathe. Patients have to use more accessory muscles of breathing in order to just be able to expand their ribs and be able to get a breath in. And so those changes in the lungs are structurally permanent to some degree, and can be made worse when we're exercising because our breathing rate changes and our tidal volume changes. And so trying to force patients into a really different way of breathing using your diaphragm when your diaphragm is in a different place. Some studies have shown that has actually increased dyspnea for patients. So the pursed lip breathing seems to be quite helpful for many patients, diaphragmatic breathing less so.
Okay, interesting. And are there any sort of hands-on techniques that you might use with your patients?
No, interestingly. Not in the stable state, not in the pulmonary rehab state. You might have secretion removal techniques where If a patient comes to the program and also complains of increased difficulty with their mucus, difficulty with clearing it, or we'll have patients with bronchiectasis who are referred, and they'll also have, of course, challenges with that. Then they may go through, in our program, separate care that is using hands-on techniques around secretion removal and also teaching patients to use the different devices that are available. But your typical pulmonary rehab patient probably would not be getting those kinds of treatments.
Okay, and you mentioned that, which quite nicely leads into the next one, the devices. What sort of adjunct devices do you guys use with pulmonary rehabilitation? Spirometry or spirometry?
So most patients are coming into the program with their spirometry done as part of their background information. So we receive the most current lung function or spirometry test. And then we would conduct their own exercise tests with them, or in some cases refer them to a cardiopulmonary exercise test. In terms of in-program devices, we're looking at research right now, looking at remote biometric monitoring for COPD patients. That includes physical activity, sleep monitoring, heart rate, saturation, and also medication use. And so patients wear those devices all the time, and they're transmitted to the clinician, and then they can actually alert the clinician to changes in the patient's status. So that's being done as a current research project that I'm leading.
Okay.
Other programs might use something like activity monitors, like a wearable, to be able to do something like measure step counts and things like that.
Okay. What about those? I forget the name of it. With the 3 balls where you can practice either blowing air in or blowing air out rather, and breathing air in to raise or lower the balls. Do you guys use any of that sort of equipment with your rehabilitation patients?
So there's, there used to be, and I think in some settings in acute care, there were those incentive spirometers that were done as a way to encourage people to deep breathing, often after a surgical procedure. Very little evidence to support those, by the way. Okay. But a lot of programs, But a lot of acute care settings still use them, and certainly done with supervision. They can encourage patients to take in a deep breath. People that have COPD don't have difficulties taking in a deep breath. They have a challenge with getting rid of stale air, basically. So we don't have a need for any kind of incentive spirometers in a rehab program. There are programs that are interested in respiratory muscle training. And so those are training, of course, the respiratory muscles, and those use different kinds of trainers where you can actually dial in a certain level of resistance. And so as patients breathe in against resistance, they will be able to train the muscles, and that can be an effective method if the muscles are weak, which some patients do have weak muscles. Some parts of the world, I think respiratory muscle training is actually quite a common adjunct to the rehab program. It's less so in Canada, I would say. And there is a bit of debate as to whether or not it's time well spent in terms of, does it really have an impact on patient outcomes, important patient outcomes like walking or shortness of breath. So some research is quite clear that it is helpful, and others is less clear. So I would say it hasn't adopted very widely across the world.
Interesting. And then coming on to probably the topic everyone listening is waiting for, COVID-19. Now, you've got a lot of skin in the game in terms of research and experience within the pulmonary world. As you've seen things progressing, what you've read in research and what you've seen about, what do you think are going to be the best ways for someone to approach and tackle a patient that they may have in clinic from what you've read, seen, what have you, also experienced looking at other conditions to help their patients for the better?
When this condition, when it became apparent that people that have had COVID-19 are dealing with long-term symptoms, and that rehab is actually something we're going to need to think about, I think a lot of us in the respiratory community immediately assumed it would be some kind of pulmonary rehab, because a lot of these patients, their ongoing complaint at 3 months was still shortness of breath. And many of them that we had, a lot of the early research was coming from people that had been in hospital. So they may have had more severe disease. And so deconditioning was also a problem. So, hey, this is pulmonary rehab, all together right there. I think, though, that as time has gone on and more information is emerging about what these patients are experiencing, my goodness, this is going to be a complicated way forward. And for patients, for clinicians, for the healthcare system to be able to figure it out. I mean, if you're a generalist physio, we're going to be relying, I think, on your skills to be able to assimilate so many different signs and symptoms in a complex, relapsing and remitting kind of a way. Our often siloed nature of how we specialize in rehab is going to be really challenged, I think, by COVID-19. And so patients are, almost every body system that you could imagine being affected, we seem to be seeing reports every day. And so we're hearing about, neuro changes and cognitive decline and mental health and pulmonary and cardiac and musculoskeletal. I mean, it's, and no obvious pattern, no obvious way that we can predict who is going to get what, and if what you have now is going to be the same as what you're going to have in 6 months. So I think this is going to be an enormous challenge about how we structure programs. And for those of us that have specialized in a few specific diseases with an appreciation for comorbidities, this is going to be something altogether different. And so, what's a clinician to do? Well, I guess, there's probably others that have practiced for longer than I that can remember what it was like when either new conditions emerged or our physio role in them became stronger. So patients that have had HIV and AIDS or other kinds of serious viruses with long-term impacts. We started with function, and there's a lot of trial and error. And if you're a clinician out there and have an interest in doing a case series or case reports for publication, we're really going back to some of those very well detailed patient characteristics and what you did and the impact and the outcomes, and putting those together to get that early understanding. I think that for a lot of patients or for a lot of clinicians in pulmonary rehab, there's probably not as much expertise dealing with people that have serious cognitive decline, or the kind of fatigue that people are reporting that looks a lot like a chronic fatigue or ME, or these kinds of conditions where you're worried about overtraining somebody. So I think we're going to have to learn from each other very quickly and not be overly turf or siloed, which isn't really the way our rehab systems are structured, at least in Canada, where patients often would have to go sort of sequentially through one kind of rehab after another in order to get all of their needs met. So yeah, it's an interesting time.
Absolutely, yeah. And I think for myself, I've had a couple of people, or a few people that I've dealt with post-COVID, and the symptoms have been so wide-ranging and varied, or the issues that they're having functionally. I suppose my big question would be, in your opinion, where should one start with them? Should you look more at aerobic training, or should you look more at strength training? So I'll give you an example. A young lad, 21 years old, COVID, lost a fair bit of weight. Strong fella, lost a fair bit of muscle and general weight as a result of it. A few days bedridden, classic stuff. Comes back into clinic, and he's got the fatigue. And his personal goal, regardless of the fatigue, regardless of breathlessness, is to get his strength back. He took a lot of pride in his strength training, his gains, as it were, and that was for him his primary goal. So, work with your patient, work towards a primary goal that they're after. If on that journey we can combine it with a little aerobic capacity increase, absolutely, I'm all for that, and I can swing that in. But what would you say would be most important, or is it function dependent per person, or are there any particular signs that we should look for?
Yeah, I think your intention would probably be the way that I would follow as well, with the lack of evidence about understanding what the long-term important thing to do is. I think I would probably go with more of a physical activity approach as opposed to an aerobic exercise approach. So I think I would, and this is based on nothing other than just understanding the benefit of being physically active. Obviously, there are benefits of having high aerobic capacity, and I'm not minimizing that, but when you look at sort of more the population-based studies, physical activity often wins there. And so if you're working with your patient, I think, having something that's more of a moderate physical activity approach versus, say, looking at a higher intensity aerobic exercise program, it seems to me a more sustainable and more function-based approach. And then, those muscle losses that happen during bed rest and deconditioning, I do think that that would be probably where I would go as well, because they are so much. When I think they could return to function fairly quickly, depending on the patient. I guess that's what we don't know. But losing muscle after bed rest can have serious implications to day-to-day function, and I think that makes a lot of sense to me. I don't really see, if they were to come into the pulmonary rehab program, I think that there would probably be a bit of emphasis on the aerobic part, just because that is where a lot of the emphasis is on when we train with patients that have COPD. But I do think that a more of a physical activity, moderate approach to aerobic exercise, and then looking at it from a function-based perspective, is going to be where we're at. And then really, really having excellent characterization of those patients. And there's no obvious way for us to do that other than publishing our case reports in a journal that people may or may not read. But hopefully we'll have the ability maybe to communicate what we're learning, and there's going to be some more research that's going to be able to identify at least what we shouldn't do, where the true risks are. But I think that we're still a ways away from that.
Absolutely. I think, at the risk of sounding a little bit morbid, it's what makes the post-COVID so interesting, because it's Wild West probably isn't the right term, but in a way it is kind of a bit Wild Westy, in that we just don't really know what's the best approach, what's the best way to go. Should it be heavily strength based? Should it be heavily aerobic based? Should it be a combination, much like the COPD that you're talking about? Functional, what way are you going? What way is your head pointing? And looking at the research coming out, that feels like you're getting 180 degrees of whiplash. Looking at the long-term symptoms that people are coming out with at this point in time, with things like the lung scarring, where do you think that we as physios can create the most gains for our patients?
So I do think that things that allow your patients to return to the things that are important to them, the mental health aspect, and the ability to be able to reclaim roles in people's lives. These, not just, I guess, Many of these people are quite young and have never dealt with anything that's come on so catastrophic in their lives before. And this may have also come on top of a period of lockdown and isolation, and they still may have gotten sick. And so, it's as much as we can do, I think, to try to enable people to return back to their roles as family members, partners, friends, workers. Like, those are going to be the things I think that are going to make the most sense. And patients are, based on the groups that I'm exposed to, they're not getting really much out there in the way of care. And so not doing anything because we don't know enough is not an option. And the Wild West, I feel like some patients are sort of right alongside you. And if we treat the problem, if we look at the problem, we might not know the etiology, the pathology, the pathophysiology of what created that shortness of breath, but we do have a few tools in the toolbox. Let's try some of those and see if they work for you. Let's try, if you're experiencing weakness, fatigue, some of those things around energy conservation, pacing, et cetera, et cetera. I mean, those things have worked for other patient populations. We don't know if they're going to work for people with COVID, but we don't have any reason to suggest that they wouldn't work. And so I think a moderate approach, I wouldn't suggest to any patient that it's wise to try to immediately go into a high intensity of anything. The long-term effects are so unknown that we don't know if that's makes a lot of sense. But if we can identify the things that will bring about the best quality of life that they can have, and hope that they will be able to return back to the future, or back to a future that will have a good quality of life for them, I think is key. So that might sound very vague, but I think that impressing upon them that you as a physio have a lot of skills to be able to treat individual problems on that problem list, even if you don't understand what might be the mechanism for that problem the way that we do for other diseases, and that working together and picking the priority and being willing to accept the trial and error approach, that there just isn't the evidence that we can turn to. So we have to rely on our observation, our assessment, our communication, and our ability to really, understand with the patient what might be their goal, at least at the moment, what that goal is.
Okay. So then what would be your top tips for anyone that comes across a COVID patient in that case, just in terms of how to deal and how to approach? What would you recommend that they go for?
I would recommend that they do a detailed assessment of that patient. I think a 6-minute walk test, if your patient's quite frail or looking like they're potentially limited in their walking, to get a baseline. The COPD assessment test has been used for COVID patients and appears to pick up a lot of those respiratory symptoms, as well as pain and fatigue and sleep problems. So taking a bit of a health status measure. Identifying a problem list with your patient and just focusing on a few of the gains that you think that they can hit. So if they're not really walking at all, then maybe they can figure out a way to do some tracking of steps. And let's look at some functional measures of walking capacity, getting physically active, looking at your energy level, doing exercise, a supervised exercise program, understanding if they are having issues with oxygen saturation, heart rate, arrhythmia issues, the safety concerns. I guess the challenge is that this doesn't sound like a once or two time meeting. This sounds like a long relationship. And so how does that happen in the, limited amount of visits that you may have? So, as a physio, I would probably start to think about developing a bit of a team with my colleagues as well, and thinking about communities of practice, coming up with a way to talk with each other once a week on Zoom about the patients that you're seeing, what you're doing, sharing information in small groups, we need to do things like that and not just try to forge out and have the Wild West. Even the Wild West, to use that metaphor, still had posses. No, but still had people working together, right? And so you can kind of feel like you're waiting for the guidelines to come up from on high, but also you probably have 5 physios that work in your community that if you could find a way to reach out and have a Zoom meeting once a week and talk about these patients that you're seeing and sharing resources, I think that could have enormous impact on how you practice, as opposed to just trying to always be feeling like you're one-on-one and very isolated.
I suppose this one is maybe a little less so COVID related, but what do you do when dealing with a patient who may have relapsed and comes back through to your clinic? How are you going to approach that? Because I think, like you mentioned, when we first touched on COVID, it is something that currently has a bit of an up and down, and the symptoms aren't quite steady. We can't really predict it. Even with something as simple as the fatigue, people will go a few days absolutely fine, and all of a sudden, bang, it hits them again, and they're like, "Damn, this feels just like it was a week ago or something." What's your approach with someone that's relapsed, and how do you go about taking them through the next steps, which ultimately could be similar to their initial steps?
Yeah, and I think that's where, when you talk about we're not really psychologists, I think that's actually where our role really comes through, because how defeating is that when you feel like you've gone so far. We have on our research project a couple of patient partners who got COVID very early in 2020, and they're quite keen to be part of our research project as researchers, and they've had relapses, and so now they have to drop out of that participation for a while. So there isn't really any hard and fast rule, of course, in terms of progression and starting again. I think that if it's like anything like COPD, there is always good and bad days. So it's not necessarily a relapse. There just may be a lot of variation on how their condition presents. And so having a bit of a plan, never being completely sedentary, always trying to have something that can be done, knowing that will still, even in someone that has a lot of fatigue, trying not to just completely be flat out if possible. But I think the psychological part, trying to help them get through those dark times when things are bad, and just coming back to you, finding ways to come back, even if they don't really do anything. Again, that's maybe not realistic if this is a paid visit, but trying to figure out the things that they can do that will at least show them that it's still a step forward, even if it feels like it is going back. I know these are such vague suggestions that it might be very frustrating to hear, but I don't think that we can underestimate the psychological impact that this condition is going to have. And so, we can always be thinking about, well, what do we do about the exercise here? How are we going to progress there? And really dealing very mechanically with these patients. But I think that we may have to brush up on our skills around the psychological support that we need to provide.
And you mentioned there, the psychological aspect, the fact that we're not psychiatrists, psychologists, but we're going to have to touch on that realm. How would you then go about helping someone build up their own independence in that kind of situation? Because also for us as therapists, I know for sure I felt it when I've had people come back with the same complaint. You feel like you've done a cracking job. You finished it off, dossier closed, case closed, and someone comes back. It's also a little bit disheartening for you as the physio to see that, whether it's an MSK complaint or a respiratory complaint. What sort of tips or tricks are you giving to them, or how are you going to help them build up that level of independence to truly believe that they can go through it and can do it again? Because I think we spoke there about what we can do, but I think the psychological aspect is so important there. There's something we need to reinforce.
I think that we need to rethink our position as healthcare professionals or providers, if that's the word, in this relationship. I think that we need to talk to patients more about what they need from us. And there are online, for COVID specifically, there are huge online communities made up of tens of thousands of people that we have easy access to. There are so many Facebook groups and web-based groups and very organized web-based groups that have leadership, and they're well structured. These are many professionals that are bringing their skills as professional people to their experiences having long COVID. And I think it's time for us to start listening and say, what do you need from us? What are you hoping from us? How can we support you? What when you relapse, when there's remitting, what kinds of things are going to be supportive and helpful? I don't really have an answer, because I haven't even been listening to patients enough, which is what I hope to do with some of the research that we're doing, understanding what's needed for rehab. But, as an individual clinician, it's very eye-opening to go onto those groups and to hear what patients are talking about and what their needs are. So I think that there's some qualitative research that has been published. Start reading that. And I would also suggest thinking about ways that maybe, as your community of practice of clinicians gets developed, that you also think about how you're going to reach out to patients about what they need, because some of this stuff is kind of shot in the dark stuff. And I think that we can really feel like we're not being very helpful when what we have to do is just talk to people.
I think it's quite interesting that you say that, and also nice that you can be quite candid about, you also feel that you can do more listening as well with your patients. It's nice to get that from the guests, and I really like that when the guests also open themselves up like that to say, hey, look, I can do it too. I can do more of that. I'm not perfect. But you mentioned there that you've done some reading online, and there's some qualitative research out there. What would you say has been the most jarring things that you've come across, that you've seen or heard from patients that they say that is lacking in their treatment?
I think that one of the strongest message I've read and heard is just the feeling that no one's listening. That, if they got sick in the beginning of the pandemic, there was a policy decision not to necessarily test everybody that had symptoms. We were told to keep away. Then that lack of that test has now prevented some people from getting care, because they can't objectively confirm that they have this condition. Many patients have very complicated, unusual symptoms that come and go, and when they report it to healthcare professionals, they're just being told, oh, well, you just have anxiety. What you have isn't real. So, and then even if they are listened to, there's not a lot of resources out there. We don't have rehab programs set up. We don't know what we're doing. We're just figuring this out. And even if we did have a better idea, there's not necessarily any funding in place or capacity. I think one of the main messages that I've read is just that sense that no one is believing me. I'm not being heard. My problems are being discounted. I can't access care and help. And so if you do have empathy, if you do listen to what your patients are telling you and what they're reporting, if you believe what they say, and if you start to go through the list and try to identify the things that are bothering them the most, and try to address the things that, if alleviated, would give them the highest impact on their quality of life, then I think that will go a long way to just not just help them functionally, but just help them as people, and help them regain some of that agency that they have over their own health. And it's been an ongoing message that I've read.
Gives them a bit more get up and go if they know that there's someone out there that's paying attention to them. And I think that's quite I think that's something that's applicable for everybody, actually. If
Mhm.
whoever you are, if you know that there's someone there that gives a damn and listens to what you say, it gives you that drive and that impetus to keep pushing for whatever the issue can be. I think that's quite a little powerful message there. Aside from that aspect of it, what would you say have been your biggest learning moments for yourself as a practitioner, as a researcher that you've seen?
I think I haven't cared for these patients, but as a
In general,
researcher,
yeah.
in general, yeah. But in general, I think that some of the messages that I've seen or that I'm kind of starting to internalize are some of the barriers that we thought were completely inflexible turn out not to be so. There's a lot of artificial barriers in terms of how, for example, research is funded, how it's communicated, how policy decisions are made about care. Things that appeared to be immovable in the past, suddenly there's all sorts of ways forward. So thinking again about the Tele-rehab and how that was going to be this enormous barrier for us to be able to implement in a widespread way. Suddenly everybody can just do that, no problem. Some of the other things, some of the important principles of research have sort of also been rather quickly, I wouldn't say tossed aside, but maybe sidestepped with COVID. Things like careful research studies done over a long period of time, undergoing strict peer review. Now we have, rapid trials that are published online for wide dissemination before peer review occurs and are very difficult to retract once the message gets out there. We have a much higher uptake, I think, of a lot of research by the general public. How many times have you heard about infection rates and epidemiological principles and whether this vaccine, with this particular mechanism is going to be better than that. And even looking at risks of vaccines and how does the risk of a vaccine compare to the risk of other drugs that we've been taking for many years without so much public debate. So I think, in some ways it's the place between research and policy has been much more public, and it's become something that is now much more exposed in a way about how these decisions are made and based on what factors. And not all policy decisions are going to be based on research if there's other ethical principles at play. So as a researcher, I've been excited by how the community has come together to solve a problem. I've been, frustrated by how, in some ways, certain barriers that we were told couldn't move can suddenly move. And I've been really grateful that I think physios have been a huge part of the response. And if we can continue to learn and work together, I think we're going to be, especially some of the generalists among us that are used to seeing patients with a lot of conditions, a lot of variety in their practice. That's going to be such an enormous resource for our profession that I don't think we can underestimate that.
Have you got any reading recommendations for people if they want to get more interested or more in depth on, be it COVID specifically or respiratory physio specifically?
So for COVID, I recommended a paper to our pulmonary rehab professionals that was actually written by a researcher in the UK. Her name is Emma Lads. And the paper is a qualitative paper where they did in-depth interviews of patients with COVID. And those patients talked at length about what their experience has been in the healthcare system and came up with about 6 or so recommendations for policy. And those can have implications for physios as well in terms of how care is provided. So I'm happy to provide that link to you. And if you just want a quick snapshot about what people are feeling and seeing, that was a very helpful paper to me. And I think I'm recommending it to pulmonary rehab professionals because, they're going to be part of this rehab environment, and understanding where patients are coming from is going to be quite key. So I would certainly recommend that. In terms of the pulmonary rehab, we have a wealth of information available to us. And if you're interested, of course, you could listen to my podcast, which is the LungFit podcast. And then also, I've been working quite a bit with the American Thoracic Society, actually. So the American Thoracic Society has a pulmonary rehabilitation assembly, and you don't have to be part of the ATS to get that information. And they have lots of webinars on papers that have been published. So if you want to get a bit of a deeper dive into some of the literature, but in a very accessible way, I would suggest you looking there. And then the European Respiratory Society has a strong physiotherapy contingent, and they are often talking about issues related to pulmonary rehab and COVID, and they've got papers, recommendations around what the research should be and where we are with COVID-19. And so I'd really recommend for your listeners to go to either of those two groups and to learn more about COVID and about pulmonary rehab.
Okay, fantastic. And could you maybe tell us a little bit more about what it is that you do on the LungFit podcast, just for listeners?
Sure. So that podcast I created because in my day-to-day communication with clinicians working in pulmonary rehab or maybe starting in pulmonary rehab, there were lots of questions about some of those, what I would call basic, but really important parts of the rehab process. So whether it's understanding the literature better and understanding research better and not feeling intimidated by it, knowing how to recruit patients, how do we think about the quality of our programs, what a particular test is. Those are sort of the nuts and bolts questions that I was getting. And I really enjoyed talking with clinicians about that and doing courses about pulmonary rehab. And I started listening to podcasts myself, and I thought, in 15 minutes, you can actually convey, quite a bit of information about a test, and it's a very digestible amount of time. So I was fortunate to get a donation from our hospital foundation to start the podcast, and we started in June. And there's a variety of things. So little snippets of clinical advice, of some larger questions, say around access and equity in pulmonary rehab. And then also a journal club where I talk about a research paper, and not just talk about the research that they're reporting, but also get into, well, what does this method mean? And what do they mean when they said this? And when this analysis happens, why did they do that? And try to help clinicians understand the whole research design and methods a little bit better. So it comes out every 3 weeks. Currently it is me, but soon we'll also be adding in one-to-one interviews with researchers and other stakeholders in rehab. So you can get it where you find your podcasts, Apple Podcasts, etc.
Okay, fantastic. And where could people find you if they wanted to get in touch or ask any questions?
So we have a website that's associated with our university. So I run the Pulmonary Rehabilitation Research Laboratory. And so the website is prrl.rehab.med.ubc.ca. So an unwieldy address, but
bit of a mouthful, yeah.
But happy to provide that link. And so you can have a look at the research that we're doing, and there's a contact spot there as well, and you can certainly reach out. And also you can reach out. The LungFit also has a contact link as well if you wanted to reach out and give feedback about that podcast.
Okay, fantastic. Any last little bits or bobs you want to give to the listeners?
Well, I'm happy that you've invited me, because pulmonary related physiotherapy is not the most predominant area of practice for physiotherapists. And in some countries, we really don't exist at all. And other professionals take on that role. And I would really encourage, people to consider this as an area of practice. It's extremely rewarding. And with COVID, it's going to be really a major area of practice, both in ICU, acute care, in rehab programs, and in the community. And so there's lots of research opportunities. It's a fantastic, I would say, highly equitable model of collaboration. I've got collaborations with all disciplines, and there's lots of room for growth and lots of mentorship. So I'm hopeful that that more and more students in physiotherapy will, especially in North America, where I think it's on a bit of a decline, will see their way toward a career in pulmonary related physiotherapy care.
Absolutely. It is really interesting, and there's so much to it. I mean, we've been talking now for about an hour and a half almost, and we've barely dipped our toe in, kind of thing. There's just so much more to go. We haven't even addressed the ICU side of things. We haven't even addressed first contact with these kind of patients. There's so much to it. But yeah, thank you very much for your time. Really appreciate you being able to come on and chat with us. Thank you.
Thank you.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know.